Thank you very much for that warm welcome. I should explain, first of all, before I start, that my own body clock is on. I think it's 3:30 in the morning, personal time. So if I kind of nod off at the podium, if one of you would run up to the front and just give me a little prod, I should just pick up again wherever I left off, and hopefully you'll hardly notice the difference. These are the sorts of things that I have been researching for about the past 15, 17, 18 years now. Conflict, which is the potentially harmful events that patients do, from aggression through rule breaking, absconding, medication refusal, and self-harm, suicide. And then all of the things that we do to try and prevent those events from occurring in the first place, or to try and minimize the outcome of those events and make them safer. So from PRN medication through special observation, manual restraint, timeout, etc. What I've been trying to find out with my research over all of this time has been to find a way of reducing both of these things to minimum levels and keeping everybody safer than they are currently. So nearly all of my research has been focused on inpatient care, and I've been plodding along getting all of this research money and conducting all of this research. Now I think I have some kind of an answer to offer you. So this is kind of somewhat of a new venture for me. I've not had a clear answer to some of these problems and not necessarily had clear recommendations for people before. I do now. So I have something that I think you can find useful for your clinical practice and something that you can actually apply when you leave the room here. So the foundation stone for this, if you like, is what we call the SafeWards model, which is a new explanatory model as to why you can get two psychiatric wards next door to each other, having a very similar function with similar sorts of patients on them, and yet one ward can have twice as much conflict and containment as does the ward next door. What this model tries to do is explain the differences, why it is that you get those differences. If we can understand and explain those differences, it means we can take what's being done on the better ward, on the safer ward, and apply it to the ward which is not quite as safe, which is the ward which is using more coercion and is experiencing more conflict events. Apply those lessons there and get a safer ward. And that means safer for us as staff. It also means safer for the patients who are on the ward. So the sources of this model are threefold. One is my own research. So I've been conducting research into absconding, large interview studies of nurses' attitudes to patients with personality disorder, large cross-sectional studies of over 136 acute psychiatric wards in England at one time, comparing those with higher rates of conflict and containment and those with lower rates, and trying to assess what made up those differences. City Nurses, which was an action research project to try and improve things which only worked partially. A longitudinal study and lots of other studies. So a big part of the learning from those studies has gone into this SafeWards model. But the second big feeding stream, if you like, that's gone into the formulation of the SafeWards model has been other people's research. And we've conducted a very, very large cross-topic literature review. So instead of doing a review of previous research just into aggression, or just into seclusion, or just into manual restraint, we've looked at all of those different conflict and containment topics and tried to amalgamate all of the learning from all of the previous research which has been done. So that took us a very long time, incorporated, as you can see here, nearly 1,200 previously published empirical research projects. And took 14 people working on and off over, I think we started producing these around about 2005, and our final, or the last report that we produced was about 2009, 2010. So some of those are already out of date now because we haven't had a chance to update them, but it gives you some idea of how much knowledge there is out there which has not been brought into a cohesive package previously. The last element of thinking which went into the SafeWards model was just sitting back and trying to make some sense out of all of this material. All of those 1,181 previous pieces of research all of my own research, which is quite voluminous, and I can tell you sometimes now people remind me of some of my own findings, and I've forgotten them, because there's quite a bit in there. So trying to order that stuff, simplifying it, trying to make some clear picture out of it so that it will make sense, not just to me, but also to you and also to the nurses who work with you, the nurses who are working on the wards together with patients. So this takes a little bit of inspiration and a little bit of filling in the gaps. And this is the simple form of that model, the SafeWards model. I'm going to step over here, and this is going to annoy the person who's recording this for the camera, because I'm going to stand in front of the screen for part of this and I'm going to go black, but that's just if I can direct your attention to the bottom line here, what you've got is we've identified 6 originating domains or sets of features of inpatient psychiatry that can give rise to flashpoints, which are particular social situations, potentially between patients and patients or between patients and staff. And those flashpoints may or may not give rise to conflict, which would be any one of those safety-threatening events from aggression through to use of substances, alcohol, absconding, self-harm, suicide, etc. And that conflict can give rise to some episode or event of containment on the part of staff, which can range from PRN medication through to manual restraint, etc. Some of the use of containment that we use in order to prevent the conflict from happening can in fact trigger it. So I might try and persuade Brian. Where are you, Brian? There you are. He might think he's a bit agitated, and I might go out there and try and persuade him to take some PRN medication, and he might not like the suggestion and he might start getting more angry. That just confirms my belief that he really needs to have the PRN medication, so I'm going to argue the case with him. And before you know it, you've got some verbal confrontation going that creates, so a minimum, an episode of verbal abuse, for example. So there you've got those. That's the basic format, if you like, of the SafeWards model. And then at every point along the chain, there are places where we, the staff, can exert an influence over what happens. So we can try and change those originating domains in some way so that they don't give rise to the flashpoints. Or when those originating domains do give rise to, we can try and stop them from giving rise to the flashpoints, stop that particular process. We can then try and cut the connection between the flashpoint and the actual conflict, and certainly when a conflict event happens, we can try and cut the connection to containment, and we have full control over the different containment methods that we use. So we can modify it at every point in the chain. We can also influence the way that patients behave towards each other, and the ways that patients behave towards each other can also cut the connection between the originating domains and the flashpoints, and between the flashpoints and the conflict. Let me just tell you what those 6 domains are, and it'll make a little more sense to you. So there are these 6 different domains. The staff team, which would be the internal structure, the rules, routine and ideology and custom and practice of the ward, the way the staff work together, in other words, to exert control over or exercise power in some way over patients. There's the actual physical environment of the ward itself and the opportunities or constraints it imposes upon nursing practice and upon patient behaviour, and in fact the general quality of the environment as well. New to me, or new, sort of new to thinking, are the influences from outside hospital, particularly patients' communication with visitors, relatives, tensions that are in their relationships outside of hospital, prospective moves, so what's likely to happen to the person upon discharge can influence the way that they're behaving now. Where the person has come from, and then all of those effects of dependency and institutionalization and what they feel as the demands and their responsibilities at home. I've already spoken about the patient community and how patients behave towards each other as being an important feature. Patient characteristics is another one of those originating domains. Lots and lots of research here on what patient characteristics, which symptoms are associated with different types of conflict behavior. And then lastly, the overall regulatory framework of psychiatry. That would be the Mental Health Act that we operate with, through to the hospital policies and the individual ward policies and the organisations under which we work. The way in which those are actually imposed, those frameworks exert some influence over rates of conflict and containment on wards. So you could think if you're working under what is potentially a really harsh Mental Health Act that doesn't allow a lot of appeals and doesn't allow a lot of complaints or whatever, and is quite authoritarian and quite rigid, that is going to evoke a lot more conflict and pushback from patients than if you have a rather liberal regime. And the same thing goes for hospital policies about what patients can and can't do under certain circumstances, etc. So those are the 6 domains, and that's the simple SafeWards model. I could spend 2 or 3 hours talking just about the SafeWards model, and I have occasionally done that at different presentations. This is just to give you some idea of how complex the full model is. So, and those 6 different, those are the 6 different domains that I've been talking of, conflict origin of features that give rise to flashpoints. In this row here, you've got all of the different staff modifiers identified. So these are all of the things that we can control, and the way we do these things has an influence over conflict and containment rates. You've got all the different flashpoints identified there as to the particular social situations that are hot, if you like, that are likely to stimulate an instant of conflict and containment, and you've got conflict and containment in a dynamic relationship in the middle. You can get all of this stuff on the internet, and I'll tell you where at the end of the presentation. I can also give this presentation as a handout or as a PowerPoint to Brian, and he can distribute it to you so you can have a good look at it and quiz it afterwards. So there will be some internet addresses on my final slide. Those are the ones that you want to write down, or if you're in the habit of taking little photographs of presentations, you can take photographs of that slide and then you'll have them written down for you and can look them up. What's the implications of that complicated model? Well, the first implication is that causality is complex and there's multiple overlapping and interacting factors involved. It's a very, very complicated area, and that means there's going to be no single solution. There's no magic bullet here. There is no one thing that you can do, no one method which is going to solve the issue of conflict and containment on wards. Some of those causal factors are outside the control of ward staff, and some of them are outside the control of anybody. So what's in the Mental Health Act is not under the control of the staff who are on the ward. Neither is the actual hospital policy in relation to certain things about what patients can or can't do. So those are things that the ward staff can't necessarily change. Some of them are outside the control of anybody because our treatments are relatively ineffective for people who are acutely unwell, and we have to manage people who are in extreme states of distress and having unusual experiences. So although there's little we can do about those things, there are plenty of choices we can make about how we respond to people. I'm not putting this terribly well. Let me try and put it a little bit more clearly. If I have somebody who's extremely paranoid and deluded on my ward, I can certainly give them the drugs that they need, that they're prescribed, that will help their relapse of psychotic illness resolve, but that's going to take time. Other than the treatments that we can give them, there's not much I can do about their paranoia, and that paranoia will make them potentially more likely to engage in aggressive behaviours. But I've got plenty of choices about the way I respond to their paranoia. I've got lots and lots of choices about how, when somebody is paranoid, I'm going to go to them, how I'm going to interact with them, how I'll suggest to them that now's the time to breakfast or now's the time to get up. So I've got lots and lots of choices about those things, but I can't actually do much about their paranoia. This means, anyway, there's no complete answer to the problems of conflict and containment. So anybody who says that we can eradicate all violence from our acute psychiatric wards is, I think, probably unlikely to be successful. just as long as we continue to compel people to come into hospital and as long as people are acutely unwell when they get there. The strengths of this model is that it identifies patient modifiers and you can use it as an ideas engine. So you can take all of those staff modifiers that are identified in the model and you can look at those and you can produce your own ideas about what to change in order to improve things and make your psychiatric wards safer places. The weaknesses of that model is potentially that it's a bit over-inclusive. Most of the things for which there is some evidence, I've incorporated into that overall model. That's because overall, the level of evidence that is available in this area is not particularly strong. It's an awful lot of descriptive studies. There aren't very many evaluative studies and not very many trials. We need more trials, and I'm going to tell you about one of those. The second weakness of this is potentially its bias towards my own research. So like all researchers, we tend to consciously or unconsciously prioritize our own findings. I've got far more tendency to believe things that come out of my own studies than things that I read in other people's studies. Whether I've managed to overcome that bias or not is something that you'll have to judge for yourself when you read the overall evidence that there is for the SafeWards model. But as an issue of fairness, I've got to tell you that I think potentially there's some of that bias in there. But it's a good model. It's a good model and it works, as I'm going to tell you now. So this is the main thing I want to tell you about, which is the SafeWards trial. What we wanted to do in this trial was to devise a set of the most feasible interventions for inpatient nurses with the most impact on conflict and containment, and then subject them to the most rigorous experimental tests we could using the best outcome measures that we could get hold of. This is the kind of process that we went through in order to get all the way through. We started from 2008 generating ideas based on the SafeWards model about the type of things that would have an impact on conflict and containment rates. Things that we could go to a ward and ask them to do, which might reduce the rates of conflict and containment on wards. Eventually, my team and I came up with just under 300 different ideas about things that we might do or things that we might ask nurses to do, based on our own program of research and based on those literature reviews that we were conducting. We refined that within our own team. What we basically did was we scored all of those different interventions on feasibility, potential impact, ease of persuading people to do them, how well we thought they would go down with patients, etc., etc., etc. And then we selected the top 30. With those top 30 interventions, we then went to 2 groups of expert nurses, people who've been working in acute psychiatry for a long time, and some people who were currently ward managers, sat them down and explained the 30 different interventions to them, and then asked them what they thought the problems with those were, which they thought were easy to implement and which were difficult, which they thought would work the best and which they thought would work less well. And we also took them to our service user and carer research group and asked them the same kinds of questions. Very interesting. We had 2 groups of expert nurses and 1 group of service users and carers, and none of them agreed with each other. They all had very different ideas. Even the 2 expert group of nurses didn't particularly agree with each other. Nevertheless, we had to make some kind of sense out of that and take their top recommendations, and we did put 15 of those interventions to one side and took the other 15. Those are the ones that we took into a pilot study last year. So for the first 6 months of last year, we were implementing those 15 interventions on 4 wards in East London. We did get some good results out of that, but primarily what we wanted out of that was the staff's feedback on trying those 15 interventions. We had some focus groups with staff at the end of that study to find out what worked well, what didn't work well, what they liked, what they didn't like, what the difficulties were. And that enabled us to drop 5 of the interventions and make some modifications to the remaining 10. and those went to a full trial during the first 6 months of this year, and it's that final full trial that I want to tell you about now and about the results of that. I've driven some people away already. Hopefully they'll come back. They're just taking messages or something. Okay, this was our final intervention list. So in the first block there, you have what was in our experimental intervention. These were the 10 interventions that we wanted to test in the trial. Clear mutual expectations was we required the ward staff to engage with the patients, have some meetings, and discuss what were the expectations of each other's behaviour. So instead of asking people to negotiate rules, what were the rules for patient behaviour, basically we asked what were the expectations of both parties on each other. We gave people some guidelines about how to conduct that discussion and what the possible topics might be, but it was down to them to devise their expectations of each other. We then got those, when they finalised those, we got them printed up on a poster. That poster was hung on the wall on the ward, and new patients who were admitted to the ward were introduced to those sets of expectations, as were staff who were working temporarily on the ward for the first time. SafeWards was we came up with a set of about 100 statements, 1 or 2 sentences long, giving staff advice on how to speak to patients or how to deal with patients, primarily in the 3 flashpoints of when the staff had to say no to a patient request, when the staff had to ask the patients to do something that they didn't want to do, and when the staff had to ask the patients to stop doing something that they were doing that they ought to stop. So in those 3 situations, we had these 100 different statements. Most of those statements were culled from my previous research interviews with staff. In previous research studies, I think I must have interviewed, about over 500 staff or more. And in those interviews, you often get some really good staff, or you get some really pithy recommendations. We extracted those out of all of the interviews and got this list of 100. And then those 100 different statements were each put on a different coloured A4 sheet, and they were put up in the nursing office and changed every day or 2. So that was SafeWards. Talkdown was a new de-escalation model that gave lots and lots of detail about the de-escalation process and methods of doing that de-escalation process. And we asked wards to elect amongst their staff team who they thought was the best de-escalator on the ward. And the person who was elected as being the best de-escalator on the ward did some background reading about the de-escalation model and then used it to talk about de-escalation to each of the other members of staff on the ward. Positive words was a really simple intervention. We asked the staff during every handover, whatever else they said about each of the patients on the ward, they had to say something positive about the people that they were handing over. And our service user and carer group gave a long list of suggestions as to the type of things that the staff might like to highlight about the strengths or the positive behaviours or the positive things that patients, even the most difficult patients, can show while they're on the ward. Bad news mitigation was about trying to pick up on occasions on which patients were likely to get some bad news. That could range from us telling them the bad news, like, no, you can't go on leave, or no, you can't be discharged yet, through to them getting bad news from outside the hospital via text message, or potentially a communication from a social worker about access to children, or some relationship argument with somebody outside of the hospital, with a friend or potentially with a partner. So we were asking staff to stay alert every time and try and identify when patients were likely to get that news, and then to spend some time with them and talk them through that so that they could ventilate their feelings to staff rather than act them out. Know each other was about getting all the staff and all of the patients who would consent to give some personal details about themselves. Not serious ones, but trivial ones, such as what books they like to read, what movies they liked, what their what their favourite food was, what music they liked, this kind of thing. And then we had those put on laminated A4 sheets for each member of staff and for the patients. And those laminated sheets were put into a special folder, the Know Each Other folder, and the folder was left out on the ward in the day room so that patients and staff could read about each other, and that would give them some focus of ordinary, everyday conversation with each other. Mutual help meeting. We asked the wards to have a meeting at a minimum of 3 times a week. This was a meeting primarily for the patients that was facilitated by the staff, and the purpose of the meeting was for the patients to identify ways that they could help each other during the ensuing 24, 48 hours, ways in which they could support each other. Once again, our service user and carer research group came up with a long list of suggestions about the ways that patients can help and support each other. They could range from very simple things like sitting next to somebody, companionably, not necessarily talking to them for 5 minutes within the course of a day, towards saying good morning to somebody when they came into the day room, right through to more complicated tasks like helping somebody do their laundry or sitting with somebody during a meal, etc. So the mutual help meeting, people were able to ask for such things from each other, but they could also make offers of those little tasks to each other. And as the meetings progressed and they occurred recurrently, they could thank each other for the things that they had done since the previous meeting. And they could even make suggestions to each other about how they could help and support patients who were not able to engage in that meeting or in that discussion. So that was a mutual help meeting. Calm down methods was a box of equipment that nurses could use when patients were getting agitated. So in the calm down box we had a set of different tactile blankets, these stress toys, different light displays, some iPod minis with different types of soothing music on them and disposable earphones, a range of stuff like that. We've got a long list. Again, you can download details, lengthy details about all of these interventions, about exactly how to do them, exactly how they tie into the SafeWards model, and exactly how they're backed up by previous research. So a box of calm down methods was given to each of the wards for the staff to use when patients were agitated. Reassurance was about completing that final stage to the debriefing process. So when there's been an event on the ward, perhaps a restraint or even some loud shouting, particularly in the middle of the night, that is very disturbing to patients, that not only would we debrief each other once we'd managed to handle the incident, and not only would we debrief the patient who'd been engaging in the behaviour, but also that we would go around and do this reassurance. In other words, make sure that we went around to all of the other patients on the ward and gave them some explanation about what had occurred. So it was about cutting the contagion, because quite often when you've had one incident on the ward, because it sends everybody a little bit anxious, it's likely to result in a further conflict event. And discharge messages was, we asked the staff to approach each patient prior to discharge and get them to identify some positive aspect about their stay on the ward, something that they enjoyed, something that they appreciated. The patients then wrote this on a card. Some of the cards had pictures on them, and those cards were hung on some kind of tree. We had, in some cases, an actual physical tree made out of twigs that was on some of the wards. Some wards had displays on the wall on which they hung these messages. And the idea was that new patients who were introduced to the ward or patients who were already there would be given a more positive view of the ward if they could see how it's helped others. So those were the 10 SafeWards interventions that we were testing in our experiment, and those were the experimental interventions. We also had a set of control interventions. Those control interventions focused on the physical health and well-being of staff and included things like desk exercises, pedometer challenges, where we gave everybody pedometers and the staff on the wards organised themselves into teams and did competitions as to who took the most steps. We provided them with healthy snacks, health, sports and exercise magazines, health promotion literature, etc. Those were our control interventions. They were to produce the same level of expectancy on the control wards that there would be some change. So just some pictures here now to break up all the talk a little bit more. This was a poster we used to encourage patients to attend the mutual help meeting, and you can see there's identified in fact the 3 different rounds of the mutual help meeting, thanking people for what they'd done for you, discussing the news and events that had happened on the ward, making suggestions as to how you can help each other in future, and making offers to each other. This was a postcard that was handed out as a reinforcer to the SafeWards intervention of things to think about when you were saying no to a patient. I rather like this one. I didn't create this. One of my research fellows created this as we were preparing for the trial. I rather like this one. So it's reminding you to, when you say no to a patient, to sympathise with how that feels, attend and listen to their feedback, listen, really truly listen and hear how they feel about it. Try and say yes if you can. Identify with the patient so that you show true and genuine empathy. If you make promises to patients when you say no to them, never forget those promises. Make sure you deliver on them. If you do have to say no, give good reasons as to why you have to say no. Don't say, well, it's because I say so, or because that's the rule here, or whatever. Do admit that we're not always right. So even if we do have to say no, this might not be a good rule, and tell the patient a way they can challenge it. Give them options. Here are some of the clear mutual expectations posters that were created by staff and patients during the pilot study, and those were hung up on the wards. On the left-hand side here is one of the Know Each Other folders. In fact, that's some details about one of the ward managers on one of the pilot wards and the sorts of things that she liked. It's not quite clear enough for me to read what her favourite TV programme was on there. But if you look at the presentation, you might be able to see it. And then on this side, there is a discharge tree. You can see the occupational therapist got hold of the idea there and turned it into something quite brilliant and beautiful. So all of those leaves there represent an individual message from one of the patients who's been on the ward about something positive about their stay. This is the talk-down de-escalation model that was hanging on the ward and was used by the ward's de-escalation expert to go through all of the other, with all of the other staff on the ward to expand the range of their de-escalation skills. This is one of the SafeWards posters that was hanging in the ward office. One of the wards liked that so much that they wouldn't take them down. So by the end of the study, they had loads of them pinned all over the various staff offices all over the place. And in fact, if you look at this de-escalation poster, one of the wards took to using this as part of a debrief process. So every time there had been an incident, they went and looked at the poster and talked about the incident, about what they did do and what they might have done to try and avert it. Another ward used this to generate role play exercises as part of staff training. This is the contents of a calm down box here, so you can see some of the stuff that's available. Very similar to sensory room stuff, but you didn't need a room for this. You could give patients this material under supervision and they could take it and use it anywhere, either on the ward or in their own bedrooms. And these are some photographs of the control interventions. So you've got health education posters, the pedometer challenge. There was one of the control wards spent an awful lot of time discussing how they were going to do the pedometer challenge fairly, as only psychiatric nurses could. They wanted it to be very rigorous with each other, and they wanted to make sure that they couldn't cheat, because there were some prizes. So they spent, I think, about 8 weeks discussing how exactly they were going to do it before they actually did it. Here's some desk exercises hanging in the office, and you can see some magazines and health education leaflets out, and also healthy snacks and fruit that we delivered to the wards regularly. So this was the sample. We were looking at generic acute wards, psychiatric intensive care units, triage, assessment or treatment wards, we were not looking at forensic units, elderly or child and adolescent mental health service wards, although I'll happily discuss with people at some stage about how these ideas might be applied there. We excluded wards that were having real difficulties at the time, so those that didn't have a full-time ward manager in post, permanent ward manager, those that didn't have a permanent consultant psychiatrist or had high vacancy rates were excluded. Also, those that had major changes planned in the 6 months of the trial, they were excluded as well. So there were 2 randomly chosen wards at 15 randomly chosen hospitals in southeast England. So you see some figures there about what the sample pool was. 7 hospitals were excluded mainly due to planned ward closures. So there's a lot of ferment in acute psychiatry at the moment in the UK, mainly because there are cuts to our services and people are having to save money. And one of the ways they seek to try and save money is to close wards, because that frees up a lot of resources if you manage to do that. So you can see there's a lot of planning, downsizing, merging of services going on at the moment. So at each hospital, wards were randomly allocated to experimental and control conditions, and all that randomization, and indeed the analysis that happened afterwards, was independent. So it was done by a statistician. I had to send my entire sample pool off to an independent statistician, and they wrote back to me by email and they told me which hospitals were included, which wards were included, and then eventually which of the 2 wards was going to be experimental and which was going to be control. I had no control over that, so I couldn't bias it. I couldn't pick the best wards for the experimental condition, for example. What actually happened was quite the reverse. We tended to get the worst wards in the experimental condition. So this is technically called a single-blind cluster randomized controlled trial, which is a great big mouthful. Single blind means that the wards that were participating didn't know whether they were in the experimental or the control condition. We didn't tell them. We said we've got 2 interventions here and we're testing both of them concurrently. So we gave the same expectation that the physical well-being intervention would have an impact on conflict and containment rates, as would the more organisational intervention. That's what we called them during the trial. It's a cluster trial because all the patients and staff clustered together on wards, and that meant there are certain statistical properties of conflict and containment rates, which means you have to make a special adjustment for that. It was randomized, as say, because it was the hospitals were selected by chance, the wards were selected by chance, and they were allocated to experimental or control by chance. It was controlled because there was a control. It wasn't that we just took some wards and did our interventions and took the rates of conflict containment before and afterwards. We had a control intervention, so we had that same arousal of expectancy, and we were able to control for the experimental effect, because whenever anybody participates in an experiment, there tends to be some kind of impact, just purely through the expectancy and through the bias of the process. And it's a trial because you're testing something. So there you are, I've unpacked the whole single-blind cluster randomized controlled trial title, and you know what it means. 8 weeks of baseline data collection. So for 2 months we were collecting baseline data. For 2 months people had a chance to start to implement these different interventions, and then for 2 months afterwards, while they continued those interventions, we were collecting the outcome data. The wards and the researchers were only informed of their allocation to either the organisational or the wellbeing intervention 2 weeks before implementation. That is so that it didn't influence their baseline data returns. Wards and their staff, as I say, were blind to which was which, and the primary outcomes were total conflict and total containment rates, and these were assessed via the patient-staff conflict checklist. Basically, at the end of each shift, there was a single A4 sheet that nurses completed. It had a long list of all the different conflict and containment events, and they ticked off how many of those there had been during the shift when they'd been on duty. So that took about 2 or 3 minutes for a member of staff to fill that out at the end of every shift. We had some secondary outcomes, which was a range of different questionnaires, and I might talk a little bit about those later. We tried to make some kind of assessment to what degree the staff on the wards actually did the interventions that we were asking them to do. So my various researchers working on this project had a checklist that they completed, which was about things that they could actually see on the ward that indicated that our interventions were being done or not. And we also had them collect a whole range of qualitative data about the response of staff to the requirements and what their reaction was to the change, because the way the wards responded to these interventions was really quite interesting and very different. This was a vast study. These were all the people who were working on the study. Even that is not all of them, because I'm not there in that picture, I don't think, and the statistician isn't there in that picture. But these are all the people who were working on it full time, 15 different hospitals, people travelling out to all of these 31 different wards, taking them supplies, taking them questionnaires, training them in the various interventions and encouraging them to implement them. So this was a mega enterprise. We started preparation for this 8 months before those researchers actually got out to the wards. We started with manager contacts and hospital visits, as you can see here, months before. We got one hospital where we recruited 3 wards instead of 2. That's because when we first went to see them, the 3 wards A, B and C, it was Haringey actually, the 3 wards A, B and C, they said they were closing Ward A. Then when we went to see them the next time, I said, no, we're not closing Ward A, we're closing Ward B. Then when we went to see them the next time, I said, no, it's changed, it's Ward A now. And then at the end, they didn't actually close any of the wards. We recruited all 3 of them and included them in the study, and they didn't close any of them. So 31 wards made it all the way through this study. We didn't have any dropouts, which is quite amazing, really, because there were lots and lots of events and changes on those wards over that period of time. Quite a few ward manager changes. One of the wards was burnt down by a patient. She set fire to her bedroom, which set fire to the ward. The ward had to be evacuated in the middle of the night. This was no joke. One of the nurses ended up in hospital with smoke inhalation. It was a pretty bad event, really. And they had to move, obviously all of the patients and staff had to move to another ward, and then they had to move again to another ward because of various other organisational changes, and then finally they moved back to their original ward when it was refurbished. Very proud to say that that ward stuck with the study and continued to return data despite all of those moves, I think, which is quite a testament to them. There were a number of trusts or hospital organisations that actually delayed some of the changes they were planning to make in order to make way for our trial. So they delayed things that they were planning to do on those wards, major changes or initiatives that they wanted to introduce, they delayed. There was one hospital where they were planning a lot of staff changes, and they delayed all of that for, I think, 2 months. So that we could maintain consistency with our study and get a good outcome. And all of those wards responded really, really differently to each of the 10 interventions. So on some wards, what was popular on some wards was not popular on other wards. Some things that were entirely acceptable in one place were not acceptable in another. It was really quite individual and quite different. Lots of staff gave their signed consent, as you can see it here. We've got lots and lots of questionnaires back. All of those questionnaires, all the many thousands of them, had to be scanned into a computer, and then each of them had to be individually double-checked to make sure that our data was absolutely accurate. If you think about fidelity to the interventions, to what degree did the staff actually do what we were asking them to do? If you look at what our researchers saw, their actual evidence that they could look at that things were being done, then the experimental wards only overall implemented those interventions to a 40% intensity. We had a lot of difficulty persuading people to introduce and to do these interventions or to do anything extra. And some wards were quite difficult about returning data and about doing the things that we wanted them to do. The control wards, you can see, managed a 90% intensity in terms of what they were doing, but those control interventions around physical health, they were more passive. You know, just the fact that they had healthy snacks in the bowl, or there was a sign that those healthy snacks were being consumed. When we went back to visit the wards, the sports and health or Weight Watchers magazines were still there on the ward and were showing signs of being used. That kind of thing was fairly easy for staff to do. The actual experimental interventions were probably a little bit more demanding of staff in terms of what they were required to do. Nevertheless, there was only an incomplete implementation of those 10 different interventions that we were trying to test. When we asked staff at the end of the study to complete a questionnaire, they were quite convinced that they did the interventions a lot. 89% intensity is what the staff said. However, there's going to be some bias there because only those people who were enthusiastic about the study were likely to complete an end-of-study questionnaire. Those people who were pretty negative or not supportive of the study probably didn't do the end-of-study questionnaire. So if you're asking me how much did these wards really do those experimental interventions, I think 40% is probably a pretty accurate figure. So being 40% intensity, what were the actual results? This is the techno slide. So you've got graphs here at the top two lines are about total conflict rates on all of the wards, and the bottom two lines are about total containment rates by shift, so an average containment rate. First dot is baseline, the second is the implementation period, and the last bit on the line there is the outcome period. The blue lines represent what happened on the experimental wards, and the red lines represent what happened on the control wards. So if we look at total conflict first, which is the top two lines, you can see that total conflict decreased on both the experimental and on the control wards. But for the experimental wards, it was higher to start with, and by the end of the process, it was lower. Statistically speaking, this means that there was an overall relative decrease in the rate of conflict of 15%, and that was significant for the experimental wards. If you look at the total containment rates here, you can see the red line represents the control wards, and you can see that containment stayed round about the same for the control wards, but it decreased for the experimental wards. And that was an overall significant 24% decrease in total containment rates. So in other words, the experiment was successful from our point of view. We showed that those 10 interventions produced a significant decrease in the rate of conflict and in the rate of containment, and were superior to the control intervention. The study statistician then had to do a whole load of tests to make sure that those results weren't biased in some way or weren't being influenced by other factors. So he tried dropping wards that had serious changes. So that ward that had the fire and all of the moves, he dropped that from the sample and then reran the analysis and showed that there was still a positive result. There was one of the wards that changed from an ordinary generic acute ward to an assessment ward during the course of the study. So we dropped that one from the analysis, and still we got the same result. We wanted to make sure that the wards with more missing data weren't biased in some way. So we didn't get, for every shift, an end-of-shift report. Some wards missed out more of those returns than others. We have to test is it the case that people are less likely to complete one of those end-of-shift checklists when the ward is more disturbed and when there are more events? Would that bias the outcome? So we tried dropping wards with 20% of the data missing, and then dropping wards with 30% missing, and then wards with 40% missing. But each time he reran the analysis, the positive results were still there. Conflict and containment rates still dropped more on the experimental wards than on the control wards. Tried dropping an outlier that had particularly high rates of conflict. Again, no difference. The results were still significant. And he's still running tests. A few days ago, I got the results of some new fancy statistical tests that he'd done. I'm so jet-lagged, I can't remember what it was. But it doesn't matter. It still showed that the results were robust. So these are really good results. They're sound. You can believe them. I haven't had the statistician's results on the questionnaires yet. I've run some of my own analyses, which are pretty unsophisticated compared to his. So these are unsophisticated and not final results, but I found no differences in the ward atmosphere on any of the scales that we measured. In terms of attitude to personality disorder questionnaires, both the control wards and the experimental wards improved over time on several of the subscores, as they did on one of the subscores of the self-harm antipathy score. The SF36 was our physical health measure because we wanted to do the reverse, turn the trial on its head and ask ourselves, was our physical health intervention successful as compared to the experimental arm of the study? Did we actually improve the physical health of staff? And I looked at all of the items on this physical health measure, which is the SF36, a standard measure of physical health. And the only one that improved on the control wards were people were more likely to say that they could walk 100 meters more than without getting out of breath than in comparison to previously. So obviously that pedometer challenge really worked in terms of getting them walking, but I couldn't find any other difference. These are not final results because the statistician will do them much better than I'll do them. But at the moment, it doesn't look like there is any outcomes on the secondary measures. Strengths and weaknesses of this trial. Well, the strengths are it's randomized. So those hospitals were selected randomly. Therefore, they are representative potentially of all hospitals. The wards were selected randomly, so potentially they're representative of all wards of the selected type. The blindness means that there was the same expectancy we would hope on the control wards as there was on the experimental wards, that there would be a positive fall in conflict and containment rates. There was a control intervention. Many of these trials just have treatment as usual for the control arm, so there isn't that same kind of expectancy. There were enough wards in this trial to actually stand a good chance of showing whether there was an increase or even a decrease or an increase in conflict and containment rates. And all of the randomization and the analysis was independent. So when I took all of this data and sent it to the statistician didn't know which were the control wards and which were the experimental wards. They were labelled anonymously, so he couldn't tell. So there was no bias on the part of the statistician. He couldn't keep on pushing the data and massaging it until he found a way of showing that the experimental intervention worked. No, because he didn't know which of the interventions was the experimental and which was the control. Weaknesses of this trial was the relatively poor level of cooperation and implementation from the ward staff. On the other hand, you might argue that that's a strength because even with that 40% level of implementation, we still got this significant result. And it may be that if we got a better level of implementation, we might get an even better result. Nevertheless, it wasn't great. And there was the null result for questionnaires so far, but as I say, that result is not yet final. So, in summary, this is the ward with the web references, so these are the ones that you want to write down. In summary, there's a brand new large scope explanatory model, the SafeWards model, and you can download the full description of that from some of those addresses there. Its test, the SafeWards randomized controlled trial, has had a positive outcome, and I'm here today to recommend to you that you implement this on your wards of a similar type. There is, as I say, that full SafeWards model description that will be published eventually in the Journal of Psych and Mental Health Nursing, and that will be an open access publication, so you'll be free to download it from there. Until then, it's available and you can download it from this Facebook group. So we're mounting a large-scale dissemination exercise. There's about 200 members already in the SafeWards group on Facebook. On that Facebook group, you can download all of the study documentation, so those full descriptions of the 10 interventions. There is a video about each of the interventions that's been constructed by the research assistants who worked on the projects, and some of them involve little mock-ups of ward rounds and role plays and all kinds of different things. So you can use those to train staff in those different interventions. There's the SafeWards model description in a simple form, a relatively easy form to understand, and also in a more complicated and detailed form, together with all of the evidence on which it is based and an assessment of that evidence. I think that just about wraps it up. I think that's nearly all that's there. There's a SafeWards Twitter feed. It's tweeted. Oh, and that reminds me, I need to take a photograph of you lot for the Facebook page. Those of you who do not want to appear on the SafeWards group page, which is closed, you can cover your faces now or put your heads down. Right, I'll just take a few more here. And I think we'd better photograph the photographers. All right. I've asked the guys here who are videotaping this session if they'll give me a copy of the video. When they give me a copy of the video, we'll make this available here as well. But you can also see all of the videos on the 10 different interventions on a YouTube SafeWards channel if you're not a Facebook type person. So you can go and look at them there, and I'll upload this thing onto YouTube as well. If you don't like any of those formats, email Jeff Brennan, and he has an email distribution list. He'll email you out the stuff that you ask for, and he'll put you on a list so that you get regular news about the SafeWards and how it's being implemented in the UK and hopefully here in the future. And we're busy preparing a dedicated website so that whether you've got anything to do with YouTube or Facebook or Twitter or not, there's still somewhere you can go. But we've got a website designer working on that at the moment, and we've got to produce all of the content, so that will probably be a few weeks or months in the future. Eventually, we want to have on that page some outline project management spreadsheets about how to go about implementing it and the resources that you require and what order to do things, and also some outline evaluation strategies so you can run your own clinical audit of implementing the SafeWards interventions. There will be a discussion forum online as part of that as well, so that you can give feedback or get feedback from other people around the world who are doing the same thing. So we're going to be seeking collaborations everywhere. And the implementation of this SafeWards model is in everybody's hands, not just mine, it's also yours. You can download it, read it. You can make your own interventions up out of it. You can eventually look at the long list of around about 300 different interventions and see whether you like any of those better, or whether there's something there that you can implement or adapt or apply to your own services. And like all sorts of research and all models, this is just one interim step on the way to some better place. I've got other research projects currently running that will give us additional information about what determines conflict and containment rates on wards and about the variation in practice on acute wards. So in another 10 or 15 years, I might have a SafeWards model Mark II, and hopefully it'll be a lot better than this one. This isn't perfect. What I can tell you is this is the best that evidence has produced at the moment, and I commend this to your implementation. Thank you very much for listening.